Hello, Dr. Dave Hindmarsh, GP Templates, and in this episode of the 20% series, we're going to look at a really big topic of how general practice gets paid. This comes at a really opportune moment because not only in this video we're going to talk about obviously some stuff for AKT revision, we're going to talk about really why the BMA have just announced their referendum, and you would have been living under a rock if you missed that out, and finally how we can use this information about how general practice gets paid to help you support your job application if you're a registrar, perhaps you're looking for another one. So we're going to give a very brief overview of practice finances, how different sources of income can affect the practice, the types of contract that we get, and then looking at outgoings, and then finally we're going to wrap all of this up and look into jobs as well. Bit of disclaimers, we're going to talk about money. So it's quite simplified. I'm not an accountant, I'm a GP partner, and I've learned a lot of this through the Medics Money GP Partnership course. I was on cohort number 1, so I'm going to leave a couple of links down below. I've done some videos on the course. It is excellent if you're new to partnership and trying to get your head around these accounts. And finally, this is not financial advice. What I want you to do, though, think about money, is think of it a bit like a bathtub, okay? So you've got bathtub that stores all the water, so they're really like your practice accounts, and you've got money coming in terms of the tap, and then your outgoings, and this is where you unplug it and money's spent. So think about sources of income. Now, all GP practices need to be under what's called a GP contract, and these are different types. And you can get other sources of income as well, such as private work and then generally education and research as well. So we're going to focus on the contracts first because this is quite a big chunky one. There are broadly 3 types of contracts. So that's the GMS contract, which 70% of practices will be under. If you're a GP registrar, your practice will be under a GMS contract. There's a PMS contract and also an APMS contract as well, which is sort of the private bit. And we'll go into those in a bit more detail. These percentages given were from October 22, so they may sort of fluctuate over time. So the core contract itself has got certain key elements. So it needs to cover a certain geographic area. You've got to maintain your practice list and give out sort of your core medical capabilities. You've also got responsibility to look after the building and also the staff of the building. And also you've got to listen to your patient group, okay, and get feedback from them. And then there are key elements as well. These key elements of the contract include dealing with complaints and that you're liable for certain things and that you must hold insurance as well. You must conform to clinical governance, and we're going to do a separate video on that because that's a whole big topic in itself. And also there are certain elements that you may want to terminate your contract. It's also a digital requirement as well, which is relatively new in the past couple of years, so it's primed for an AKT question. So cloud-based telephony, which is being really pushed at the moment. You must be able to offer video consultations and also online bookings. There must be a 2-way secure communication, either through e-consults being one example, so people emailing in, or via the use of text messaging, so AccuRx being an example where you can respond back to it. You must offer online requests for a repeat prescription, and you must maintain a website, and that website has to hit key certain standards in order for to be compliant to this part of the contract. And also, relatively new thing as well is that you must allow digital record access. So the GMS contract, or General Medical Services contract, it covers 3 main areas. That's the global sum, QOF, and also enhanced services. So the global sum is basically how the practice population affects your payment. So the larger practice population you've got, the more money you're going to get. But you can already suss out and understand that that's not really fair. And so they use what's called the Carr-Hill formula to then adjust how much you're paid per patient. That then gives what's called a weighted patient list. And then that weighted patient list is then calculated to basically your global sum. So the Carr-Hill formula itself takes on certain factors, your patient's age and sex, any additional needs that they may have, and also list turnover, realising that new patients take up a lot more effort and time. Likewise, staff market forces. So for example, if you live in London and there's sort of the adjustment for that you'll get paid a little bit more. Likewise, if you're rural, there's a lot more travelling costs, there's a lot more additional logistical costs as well, and that's factored in. So QOF just at the end of the QOF year when this has been filmed, so no doubt there's a bit of a sigh of relief as we sort of see how things are totted up. This quality and outcomes framework, and most chronic conditions are covered for it, and you would have seen it. There'll be set targets that you need to hit. For example, I'm diabetic lead, so for certain patients with diabetes, they need to get their HbA1c under a certain level to achieve that target or have a good reason for it. There's minimal standards, which is deemed good care, okay? And this is another bit why people have sometimes in the past got a bit upset about QOF and still do to a certain bit, because the levels that they're hit, say, for example, with diabetes, aren't particularly hard. And so actually, are we improving patient care from that point? So the key point from QOF to hit it, it's all about read coding. So coding. Have they got the necessary blood pressure coded in, not just free typed in, because that will affect the payments towards the end. Also the prevalence data. So big one that I've seen is chronic kidney disease. So you get an abnormal renal function. They've had an abnormal renal function for absolutely donkey's years, but no one has coded that they've got CKD of whatever value. And also about hitting those targets. What happens if you don't? Have you got systems in place that can help you support it? And you would have seen different one. This is just a test patient that I robbed off the internet. You have this QOF timeline. You can see in green that certain elements have been hit, and in red that they haven't been hit. So the enhanced services, there are two elements to this. There is the direct enhanced services, and they vary year on year. Okay, and every practice must offer these. And in the 24-25 contract, they're looking at things like improving health outcomes and reducing health inequalities, targeting resource efforts, and then finally enhanced access. There's also a locally enhanced services, and that's sort of agreed individually depending on your ICB and what you can do from that way. What's interesting then from a AKT question point of view, because the locally enhanced services can vary so much, it's unlikely or it's unfair that they can ask a question about the detail of that. But for the direct enhanced services, because it affects everyone, it's probably worthwhile that you're aware of this. And I'll leave a couple of links below so that you can go have a look for it yourself. If you're enjoying this series, this is video number 6, which is somehow sort of crept up on me. I've got a whole list of videos that should help you with your admin and statistics part of your AKT revision. So please have a look at the channel and go and take a look. So the personal medical services, or PMS contract, is locally agreed services. So it can be directly to the individual practice or an individual. And the whole aim of it is for the ICB or whoever's commissioning a service to add that extra level of flexibility and add a greater skill mix. And in hard to recruit areas that are sort of maybe deprived, it's trying to support that area to see what they can do, because they may need to be thinking outside the box or do something a bit different to your standard general practice. Finally, you've got alternative provider of medical services. So for me, it's locally, all of our sexual health services are provided by Virgin Healthcare. And so it's basically any private company that are coming in to provide a set service. This can include essential, enhanced and additional services from a wide range of providers. So I've mentioned Virgin being one, but there are loads out there. So let's think about other sources of income. Okay, so we've covered general practice contract in a bit of just as a brief overview, and think about private work, education, and also research. So private work, you may get this, and you may have had, say, when you're debriefing with your supervisor, that you've done something and you said, have you charged for that? The classic one being certain letters that we don't routinely provide, i.e. sick notes under 7 days. It's not part of the work, it's not needed legally, but if an employer is insisting on it, well, actually, I'm more than happy to do it, but that's private work. Thank you very much. There are also certain insurances, thinking about firearms licenses being an obvious one, and certain medicals. So for DVLA or certain work medicals that we as general practitioners can do, but there is an additional charge to them because it's not covered under the GMS contract. Certainly with some minor surgery, it may be this isn't a tricky area because sometimes it's covered by the DES or a locally enhanced service, but often you get an extra payment for doing minor operations, minor procedures. Think about not just cutting out lumps and bumps, but insertion of myarena coils, depot the implants themselves also will boost up financial input from that way. Education is can be a really lucrative source of income as well. Whether thinking about medical students and, a slight conflict of interest. So one of my job roles is with Hull York Medical School, and so I try and recruit practices, and I often lean on the financial benefit of having medical students in there, and also think about registrars as well. Not so much for the financial input, and this is where the balance has got to be had, is that you're clearly to do service, i.e., you've got to support having weekly tutorials, debrief time, then that will reduce the capability of the GP to see patients, okay? And then that's got to be balanced against the financial reward that you'll get for this. One area that isn't covered is that there's clearly a need for research to try and push forward primary care and push forward sort of medical enhancements from that way. Most companies then, or most sort of research elements, will offer a financial reward if a practice is willing to get involved and help recruit patients. And they'll often say, set a number of, say, for example, can you recruit 500 patients? And once you hit that target, we will pay you this amount of money. Again, as similar with the education part, it's about balancing of time that is required to get that resources done, to send out those text messages to recruit, versus the benefits of the financial reward. So let's go back to the money bathtub, because this is where we're going to try and sort of pull a couple of bits together. And we're going to talk about partnership and how the partners buy in. So effectively what the partner does is that they will contribute a certain amount of money to their bathtub. Okay, and you can do it a couple of ways. If you own the premises, then often that buy-in will be quite substantial. So you might need to get a loan or a mortgage to then contribute to that bathtub. Or like me, where we don't own the building, so I had reduced drawings, so how much I was getting paid per month to effectively top up the bathtub. As we talked about paying out, so out of the drain, as it were, you pay your staff salaries. As part of that, you will pay your staff as well and pay the partners. So the partners will agree on a certain amount of drawings. Now, the benefit then, and why a partnership is a good model in my opinion, is that they are then subsequently rewarded if financially it sort of does really well. So, for example, there was a financial incentive to deliver the COVID vaccinations a couple of years ago. Certain practices really lent into that, and subsequently the partners and the partnership would have got potentially a payout from that. So normally the practice manager will or between the partners as well, will agree a level that they want sort of sitting in the bank, so sitting in the bathtub. Any more than that, they saying, well, hang on a second, let's reward us for doing so well financially by a certain amount payout. So outgoings. So let's think about where the money's going. The big one is staff costs. Paying salaries will always be one of the biggest bills, okay? And that's sort of where the majority of the money will go out. But think about other things as well. So office costs, clinical consumables, so your syringes, your needles, your gloves, all of those low-level stuff. Building costs, so gas, electricity, internet, interest and depreciation. So as a building or a facility gets older, it's basically going to lose value. Don't forget as well subscriptions. So this is an interesting one. Those things like I've mentioned AccuRx already, that's not free. There is a financial subscription associated with that. Even certain medical equipment now will have a subscription charge to it. So we've had the referendum. Why? What led to this point? And it's effectively this. And this is a brilliant article by Pulse, and I've sort of referenced quite a few from there, that effectively the GPC contract is being uplifted by 2%. And you think, well, hang on a second, is that a lot? Is that not a lot? And in short, the answer is nowhere near enough. The issue is to do with balance. And as we've sort of seen here now that we understand what the outgoings is, that there are certain things that are being increased in terms of the outgoings. So such as the cost of living rise, and that's having a subsequent impact in terms of your utilities bills, so your gas, water, electricity, subscription costs, because the companies further up the chain are feeling that and passing it on to your consumer, i.e. the general practice, and also wage increases, rise in minimum wage, and also sort of going back to the cost of living, that clinical staff requiring a wage increase as well. So what's the risk? The risk is this, that if we reduce the money coming in because it's only a 2% and not in keeping with the current cost of living, is that effectively the bathtub becomes empty because we're paying more out than we're getting in, regardless of the other areas of income that I've talked about. The GPC, or the main sort of stem of your money, is through that contract. So there's a risk that if the bathtub becomes empty, that practices, unfortunately, will have to close or go under. What ultimately, and starting to happen before you get to the point of the bathtub being empty, is that the partners will take reduced earnings to try and sort of compensate for that, to a point where in certain horrible situations where the partners are taking less than salaried staff to try and keep the business afloat, subsequently called zombie practices, because they're just not paying themselves and they're there almost out of goodwill. So what's the next step? So the vote got a whopping 99% of no as to accepting the vote, even more than that. And so there is talk now between sort of from the head of the GPC that they're wanting close to an 8.7% rise versus 2% to try and keep business practices afloat. And that actually, whether will this lead to industrial action? So that aside, how are you going to get a job out of this? So being aware of the situation and the pressure that practices are under just makes you tune your mind in to basically be empathetic over to your employer about what they want. Okay, so in my mind, I would say like, right, well, what can you do now to maximize income? Okay, so that's one way. What can you do to get that more water into the bathtub? So thinking about not necessarily finishing your registrar training, but think about your 5 to 10 year plan. What do you want to do to progress yourself? And can that have a positive impact to the practice? Think about, do you want to be a GP trainer so you can bring in a registrar and earn sort of financial income? Likewise, if you engage with the local medical school, similar situation. Are you interested in minor procedures and minor surgery? Could you do it that way? Could you do, say, implants, whether that be Mirena coil or something like that? Likewise, what could you do now? Now, the best thing to do in terms of from a financial element is to not spend the money at all. And you've got the opportunity through your QIP and QIA projects to demonstrate efficiency. Okay, so whether that be whatever project you've done has reduced, say, for example, the need for a consultation because you've done it all virtually, or have you been able to maximize a QOF output or a QOF point so the practice would sort of maximize benefit from that area. I've got a video about how to smash the QIP. I'm going to leave a link to that below as well. And so it's just sort of thinking about what you can do now to sort of maximize the efficiency. And when writing up your QIA or your QIP, making sure that you add a financial element to it. And I would do this in terms of how many hours you've saved, say, a certain member of the practice team, and then equating that to their wage. So, for example, you may pay a salary doctor, for example, say for the ease of maths, £100 an hour. Because you've saved that salary doctor 6 consultations at 10 minutes a piece, that's an hour of work. You've saved the practice £100. Thank you very much. Brief overview. We've done an overview of practice finance. We've talked about the main source of income for a practice, regardless of other bits, is through the general practice contract or GPC, with GMS being the majority type of contract. There are other income streams that you can sort of have a look at, and we've looked at sources of outgoings. And because we've used that knowledge, we've sort of making sure that we're aware of why there is current unrest and the current situation with what the GPC has been offered, and also how this information can really help us out not only with the AKT but with job applications as well. As I said, we've got loads of videos on the go now, so we're currently building up. Please make sure you share these videos around to help those who are revising with their AKT and struggling with the stats and the admin part of the AKT, because this is all where these videos are targeting, hence the other 20%. Dr. David Hindmarsh, GP Templates, very, very best of luck to you.